Good morning, everyone. I'm very glad to be here with you today. My name is Sam Finn. I work at Californians Together, and we are proud to partner with the California Departments of Social Services and Education in supporting the CalNEW program. We hold this webinar series so that we all can come together as professionals to become more knowledgeable about how we can best serve newcomer youth. And to do that learning, we invite some of our state's leaders in practice to teach us a little bit more about what they know. And so today our expert speakers are going to share their knowledge on supporting the health and well-being of immigrant youth. And this is always an important issue, and it's an especially important issue right now. So a brief overview of our time together today. We're doing our intro now. We're going to start by hearing a district level approach to health and well-being from San Francisco Unified. Move next to hear about the Fuerte program, an exciting mental health pilot from UC San Francisco. And we'll conclude by learning more about mental and physical health from our friends at the Stanford School of Medicine. If there's any extra time, we'll do a panel discussion at the end, and we'll have about 5 minutes for questions after each presentation. Now, let's do a little background on programs supporting today's webinar. The CalNEW program was developed by the state legislature in 2016 to provide supports to socioeconomically disadvantaged newcomer youth and their families through the school system. This initiative provides grants to 21 school districts across California and is increasingly looking at ways to spread knowledge and best practices. And every year, the CalNEW program is proud to support districts and staff who show incredible dedication to supporting basic needs, engaging families, and developing youth academics and leadership skills. A quick plug for our next and last webinar of the year. On February 20th, we will have 4 national experts discuss designing district academic programming. Think about academic pathways, think about program models for within school academies or whole school academies or summer or Saturday schools, curriculum, instructional approaches. Lots of excitement. Highly recommend. You can sign up on the California Newcomer Network, or maybe someone will put that link in the chat. But you can go to calnew.net and find the webinars tab. In any case, please use the Q&A feature on Zoom to ask any questions that you might have. Questions might be addressed by presenters immediately after the presentation, or they can write in the Q&A feature. All of the recordings, the slides, and any materials mentioned today, we'll send in a follow-up email a couple days from now. And in the next week or two, we'll also host on the California Newcomer Network website. And with that, I'm excited to turn it over to Angelina Romano at San Francisco Unified. Thanks for being with us, Angelina.
Thanks so much, Sam. I appreciate being here with all my other fellow colleagues. I'm hearing a little echo. Is that just me? I guess so. Hold on. I'm going to try my headsets. Anyway, my name is Angelina Romano. I'm a central school social worker at San Francisco Unified School District. I've been in the district for about 17 years, and I've been the district coordinator for our RISE SF program, or Refugee and Immigrant Solidarity and Education. RISE SF focuses on 2 buckets of service that are overlapping: sanctuary education and newcomer programming. And today we're going to focus a little bit on health and well-being, at least the work that we do with newcomers centrally to promote health and well-being at school sites. So first I want to start just by saying that I'm a little distracted today, as it's been a really difficult 3 days. And this day in particular, there's been a lot of rumors around immigration and customs enforcement being in the city. A lot of our families and staff are worried. So I've been like a little nauseated a lot of the day and trying to be present here. And one of the things that I like to think about during these times to find my hope is solo el pueblo salva al pueblo, which, for those who don't speak Spanish, only the people save the people. This was a quote that I believe came out of after Hurricane Maria in Puerto Rico. And it's also been something that has come up during the floods in southern Spain, the hurricane in the Carolinas, the fires in Los Angeles. Um, I mean, on and on and on, right? Thinking about all of the ways that we come together in radical community when the time calls for it. And I think sometimes we can feel like, oh, what are we doing? Where is everybody? What's happening? Um, and I do believe that we come together with mutual aid when it's needed. And I also think it's important for us to remember that while we make up institutions, institutions can't always be there to save us, but we are there to save each other. We can hold institutions to the fire, we can push the needle forward, but we are the ones that take care of each other. And I remember in particular, back in the first time around, when we all showed up at the airport here, at least here in San Francisco, I should say, we showed up at the airport when there was a travel ban. We were outraged when they were separating families at the border. And while a lot of harm was caused, we did rise up and come together in times of crisis. And so I really have to hold on to that belief as we move forward in the next 4 years. And this is also related to all of our mental health and well-being, right? Knowing that we have each other to rely on and that we can come to each other in times of support. When I think about our newcomer young people and families, and when I think about health and well-being, I try and remind myself and the staff that we support at schools that mental health is universal. I think often we get into a place of thinking that mental wellness is somebody else's thing. Like when we think of our newcomers, we tend to start othering them in terms of what they need and how we can get them therapy, how they need to get fixed because they're not properly fitting in, right, to our institutions. And what I really try and remind us all is that every member of your community is trying to heal from some past or current harm, whether it's a teacher or your principal or your security guard. And all of that means that they can also get triggered. They also have challenging responses, right? And every school is its own living organism, working together, breathing together, and we're not just in isolation. So all of that harm and trauma comes together. It's not just our young people and our caregivers that need healing. We all need healing. And if we can approach our school sites with that in mind, it can really revolutionize how we think about interventions, how we think about mental health and well-being, not just as something that happens over here with a young person, but something that we all participate in. I think it also helps to give each other a little bit more grace and humility. It allows us to be a little bit more accountable to ourselves, like, oh, that was triggering for me, and I totally responded how I shouldn't have responded. I yelled at you. I really apologize. What can we do to sort of repair this harm, right? It sort of allows for a bit more grace from all the adults in the space and not to feel like messing up is bad, messing up is mental illness, and that only happens to others, but that we all participate in this and can reach out for help when needed. Also, I see things in the chat and I have to tell you that I'm not good at multitasking. So hopefully I'll see it later and Sam can uplift anything that comes up in the questions. I know we have questions at the end, but just to let you know, like that's not a strength. So in the school district, I try and help folks think about how to offer interventions, whether it's behavioral health or anything in this sort of response to intervention, which is parallel, right, to the public health response or MTSS or, tertiary prevention, all that kind of stuff. So response intervention and that hyperlink there, once you have the slides, is to a sort of newcomer program planning guide that I created a while back. It's certainly could use updating. It's not comprehensive, but it's something that you can use to think about in your districts or at your school, how you might create something similar. So for those of you who know, RTI came out of a way of making sure that our Black and Brown students and DL students weren't being overly referred to special education, right? So it was instead of jumping to tier 3 and thinking the problem lies within this young person and they need something, it was to think about how we're offering other interventions before we jump to special ed. I think that originally this is a triangle, how this is usually presented as like you do this thing and then you do the next thing and then finally you can refer them for special ed, right? Like it was just boxes that you click off. I don't believe in linear living. So I created this graphic as sort of circles happening within each other. So we think about how we can create transformative institutional change and then interpersonal change. So you to me, right, our young people to each other, teachers to young people, but also maybe in specific population groups, affinity groups, whether it's by language or gender or what have you. And then even focusing more on personal change, which is both for the young person or the caregiver, but also for me. How do I create personal change within myself so that I can affect transformative change within the school, right? So it is a layered framework. I don't want to think that one thing happens and then you go on to the next. They all happen simultaneously, yes, to create this kind of change, hopefully, with the sort of focus, right, on healing. So when we think about universal transformative change, these are just some examples of things that I try and promote at school sites to think about how they can create foundations of healing with their families. So first and foremost is the first day a family comes into a school can be the most important day. And I think a lot of schools take for granted how little families may actually know. And to be fair, this isn't just for newcomers. This is for all families, whether they're transferring to your school from another school, they're coming from another state, um, making an assumption that anybody knows how things work at your school can lead to problems down the road. So starting with a real warm welcoming where you're able to share information with families, both receive information about them and their needs and their desires, and also to let them know what your school is like, what your values are, what your attendance policy is, what your cell phone policy is, dress code. We're going to be calling you all the time, just so you know. It's also an opportunity to get to know what their family dynamics are. So what often happens is that we don't spend time with a family until there's a crisis. And then we're like trying to build trust, institutional and relational all of a sudden because a crisis has happened, instead of like trying to do the work on the front end to build the foundation of trust so that we're ready to go when things pop off. Now, I know who's got time to build relational trust when you're putting out fires every single day. I know that's like an impossible ask. And there's a thing that says trust your struggle. Like there will always be a struggle, and the struggle is the work. The process is the work. So you keep going. You build something amazing, and then half your staff leaves, and then you have to build it all over again, right? Like it's just how it is. So trust in that. Lean into it. Believe me, I've been there. Offering families tangible resources is a really amazing way to build trust. Here's some bus tokens. Here's a backpack. Here's a folder to keep all your stuff in. Um, that's what families are looking for more than anything, is like something that is tangibly helpful. But also keep in mind that giving a family a stack of papers is just going to go in with all the other stack of papers that they've been getting from immigration detention, from their medical provider, from Medi-Cal. So it's a lot better to like be able to have a conversation with families and do things with them, right? And help them understand. Some of the other things that we're looking at schools in terms of tier one is really thinking about how equitable and inclusive your program is, what it looks like in your hallways. Is your staff multicultural, multilingual? Again, I know some of these things are not all that feasible, but we're working towards it, yeah? Thinking about your classroom and instruction, and I have links there from some websites that offer some things around how to do a welcoming classroom. I believe it's Colorín Colorado, and I can't remember the other one, but around also having instruction that's a little bit more welcoming for young people and really trying to have more active voice and participation in the programming that you have. Can really help a family and a young person feel welcome and feel like you see them, increase a sense of belonging, and increase the chances that they're going to come to you when they need support. I also think I wanted to say that doing the welcoming in the beginning also helps you understand what the family dynamic is, because so often our young people are reunifying with somebody that they haven't been with a really long time. And if we assume that this is, you know, a unit that has been together forever, like it causes some friction when we're reaching out to them and we're making assumptions about what a family dynamic looks like. So that's an important place to sort of figure that out and do, a brief assessment of family needs and family experiences, get some history also. If they journeyed to the US by land, what that was like, why they left their country, can sort of, even if it's brief, start giving you an idea maybe of some things that are going to come. It doesn't have to be a deep dive into trauma. It can just be a little bit, yeah? And then we also need to think a little bit about how we do restore harm in our communities and create systems where we aren't building on the school to detention, school to deportation pipeline, where we're creating systems where we can repair harm, where we have values set in place, where our community understands here's how we hold each other accountable, right? When things go awry. Of course, within, your district's policies and laws, but still having time for mediations, even peer mediations, because young people talk to each other, they rely on each other more than they rely on us. So really being able to tap into our peers as resources is pretty important. Having opportunities to do PDs with our staff and build competency there. And then really intentional student and family engagement beyond an ELAC, but also utilizing young people to support each other, to build those social networks with each other so that they know that they're not alone. So often the immigrant narrative and the struggle is like in isolation, right? So having these opportunities to meet with each other can be really meaningful. And the best way to do this stuff is in meetings and reunions that are celebratory and joyful and involve food, lots of food for our mental health. And I'm totally probably talking a little too much, so I think I have to move forward. One of the things that we like to think about also in terms of what interventions we're offering young people and families is where they might be on this process of acculturation, or what's the other word for this, or cultural adaptation. Now, our goal here is to help families and young people keep a balance between their culture of origin and the culture here. All research has shown that the more a young person can keep a balance and doesn't fully just assimilate into US culture, but is able to hold both, the better their outcomes are in mental health, in substance use, in their grades, in graduation, everything else. So what we really try and do is keep this balance as they move through this, right? So all the context and variables of a young person, their internal and external resources impact how they might be able to move through this. And of course, nothing is linear. So they move all throughout this too, right? Like you can be in culture shock when you're in immigration detention, and then you're in a honeymoon when you're back home, when you made it to your mom, right? Or like when you're at school, and then something happens on the bus and you're back into culture shock, but then maybe you started going to after school soccer, and so you start moving a little bit more, right? But it's important to think about, try and assess like where a young person and family might be, because that can change what you're going to offer them. So when they come into you and they're in a honeymoon phase in the beginning, it might not be the greatest time to say all sorts of things about trauma or whatever. You might be able to start a little bit of conversation around that. They might not be able to hear it all, right? But they are really open to hearing information during that time. And then it's hard to start trying to give that information when they're in culture shock because they might not be there to hear it, right? So I just want, I'm not gonna get all into like how one moves through it and how we can support the movement through it necessarily, because it's a little bit too much for this, but it is something for you all to think about and keep in mind, both with RTI and then process of acculturation as like layers of thinking around interventions. And then the last thing here is around some of the considerations, areas of focus or areas of awareness, things to think about when we're considering where a young person or a family might be at, and some of the things that might be impacting their well-being that we can offer interventions around. So things like environmental stressors, what neighborhood they're living in, what their housing looks like, if they're all cramped into, one room together with all family members, right? Do they have peer supports or not? Is there a time difference between here and their home country so huge that they can never talk to their friends without staying up until 3 a.m., thinking about their family dynamics, like I mentioned, remembering how hard it is to learn English, how exhausting it is, and how much that impacts them, and how being able to be in affinity with somebody who speaks your language can be like just a break during the day, and how much they need that, right? And thinking about all of their basic needs, especially around legal immigration, how much trauma that causes, and the fear, and especially now about like, what's the point? Am I going to be able to stay here? Nobody wants me here. Thinking about all the things that are in the zeitgeist now that Trump has said during his campaign that we keep hearing like that, even if some of it was like ridiculous, like it sits with people. And then, of course, all the ways that we can build community with young people, but all the ways that it's hard to acculturate and adjust when you feel that deep sense of loneliness, when you don't feel like you can reach out to your family back home because you don't want to burden them, when you're hearing things in the hallways, but you can't always reach out to adults about this stuff, because sometimes it just makes it worse. So all these things are like, just little spheres of influence in a young person and a family's life that we should consider. And so I want to end on, I mentioned before, but really the importance of radical community and joy as a part of all of our mental health. And, I know a lot of people are trying to do like know your rights events, and which is wonderful. And we should definitely do that. And you can do it in between student performances and spoken word and awards, and you can talk about EL reclassification. We can do all of the work while we're also celebrating each other and eating food and finding joy. And I just want us to know how important that is for our mental health, and not to let them take that from us. I think that's it, right?
Thank you so much, Angelina.
Mhm.
Um, the note of intentional joy for everyone is a very good one to end on. And I'm going to ask you a few follow-up questions. And if anyone else has questions, please feel free to drop in the chat. Um, One thing that I'm wondering now, and you spoke a lot about giving grace to colleagues and how everyone, both students and teachers and staff, are in a difficult time right now. I think there's so much uncertainty for students and teachers in how we should be talking about things. I'm curious what advice you have for the group, whether you're a principal, whether you're a teacher, whether you're front office staff, how should we be talking to students right now, given the uncertainty?
I think that so one thing is like, should we talk about it at all? And the reality is that they know, right? It's in everywhere. Like some of our scares have come from TikTok. So like it's there. Everybody knows about it. So don't be afraid to talk about it. I think it's important for us to be united in our struggle and to recognize that we're all under threat right now. We're all in it together. This struggle involves all of us. And I think it's okay to be quite honest with young people and families
Yeah.
that you are scared too. So I often talk about the difference between talking about things being safe and moving to things being brave. Safety is a privilege, it's often an illusion, but being brave is a more active stance, something that like we all have to go in together. So telling families that you're going to do your best to be brave in this moment and to take care of each other. I also think if a family and a young person comes to you, it's really important to center their needs and their asks. If they're telling you they're scared, you don't have to jump to a solution. You can just listen to what they have to say and then ask if they want anything from you. Because I know that there are some families that are like, I mean, before we get deported, we're just going to go anyway. So some families, may not need you to do all of this kind of work for them. They might already have like their own plans.
Yeah.
Um, One last thing. I also know, though, that because each school is its own organism, relationships within each school are different. So it's really important. What I would say to a principal would depend on what their school is like, and what relationships they already have built with their families, how often they come through, all of that stuff can really change how you would respond.
That is really helpful. And from the chat, I'm also going to ask, um, can you please repeat the phrase, safety is a privilege and bravery is a...
All my one-liners. Yeah.
They're
Safety
in
is a
demand.
privilege and an illusion. And I don't think I had a one-liner for bravery, but I usually just say, like, let's move away from a safe space and let's create a brave space or a braver space. That's what I try and have folks think about.
I like that. I'm going to end with one more question before we move on to our next presentation. You've been working in social services in support of newcomers across multiple administrations and different legislative contexts. I'm curious with regards to public benefits access, with regards to FAFSA, with regards to any of these interactions with government programs. What advice are you giving right now, whether it's to students or other colleagues, whether
Yeah.
it's within, and is it different by context? What are your thoughts on that right now?
I mean, I think currently nothing has changed, right? Public charge hasn't been reenacted for those who don't, or like they hadn't changed it. So public charge, right, is for those who are trying to adjust their status, eventually their immigration status. I think it's like to citizenship, right? That they're often asked by an immigration officer, have you received any cash aid? Which they're usually not eligible for in the first place. And it's only for certain immigration categories, right? Like it's all so confusing. But so a lot of families decide just not to take anything because they don't want to be in that office and somebody asks them something and they don't know how to answer. They rather just say no. So while I do the education of like, no, it only applies to this and it only applies to that, nobody is in that office with the immigration officer with the family except the family, right? So it becomes really hard for us to be like, no, 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 you're okay, you're safe when, well, I don't know that, right? So all you can do is offer families education and information, hopefully connect them to an attorney wherever they might be, so that they can get like a consult about their individual situation and what the risks are on all of that. Now, FAFSA, you know, at this point, it's okay too, but I do know that Project 2025 has talked about going through like FAFSA, like going through all sorts of financial aid stuff. So I don't really know. I don't have great advice around that, Sam.
Thanks for thinking it through out loud with us. I
Yeah.
think that is useful so we all know where we are in our thinking together.
Mhm. Yeah.
Um, we're going to move on now. Thank you so much, Angelina. And we're going to move to Will Martinez at University of California, San Francisco. Tell us about mental health and the Fuerte program.
Thanks, Sam, and thanks, Angie, for saying the quiet part out loud. It's been a hell of a couple of days, and like everyone else, we're all a little crispy right now, but I'm glad to be ending my day today, with all of you and folks kind of in the same struggle. And a good reminder to staying focused on the work. There's a lot out there that's trying to take our focus away, and I think that's by design. And staying focused on the work at hand and the communities that we serve is important. So this is a good reminder. So I'll tell you a little bit about myself. Will Martinez. I'm trained as a clinical child psychologist. I'm an associate professor of psychiatry and behavioral sciences at UCSF. I work out of San Francisco General Hospital. I lead our outpatient programs for kids there at the hospital. These are all kids on Medi-Cal. And we serve a large proportion of those youth are immigrants. I'll incorporate some of that today, but I'm going to talk to you about the Fuerte program, which is a program that we started here about 5 years ago. Actually, more than that. What am I saying? Like 7 years ago now, in San Francisco. So, trying to figure out oh, here we go. Okay. So to give a little bit of context, and this is going with what Angie was saying about, not trying to medicalize a lot of what these kids go through, but coming from on the specialty mental health side of things in the child mental health system, what we were seeing at the time and still are seeing honestly today is that for many of our newcomers, from the point when they start to experience concerns, it takes a long time for them then to access services. And a lot of these kids have already, high risk for experiencing behavioral health concerns, including risks that happen before they migrate to the US. A lot of the reasons why they're migrating, whether that's exposure to violence, domestic violence, child abuse, community violence, war, conflict. Many of them may experience trauma en route to the United States, and then many continue to experience traumas here in the United States, related to our anti-immigrant kind of political climate, to communities that they live in that may be also experiencing community violence, and many of these other stressors that come with being a newcomer here. And then there's a number of disparities or differences in how they access treatment. And a lot of this could be for a number of different factors, for our newcomers that are of low socioeconomic status. That is a big barrier at times, just having the resources and funding to access things. Language access, especially for folks that are either languages that there isn't very many mental health providers speaking that language, or they're just in areas where there really isn't any other availability of a language other than English. As I mentioned, our anti-immigrant policies, documentation status, although with changes with California, most that Medi-Cal should cover for most, but that's still an issue in terms of anxieties around accessing care. Angie touched upon some of those points. What we refer to as low mental health literacy, what this just means is that many of our newcomer students, particularly those that are coming from more rural areas of countries in Latin America, they have very little exposure to what mental health is, how to access it, and then in particular for most of them, if not all of them, they really don't know how to access mental health care in the US. This is a difficult system for US born folks, even for professionals to sometimes understand, but our students don't, and they don't understand how to identify when they need to access help, or just basic coping skills like how to relax, relaxation skills, strategies for coping, etc. And then many feel isolated. I may be speaking to the choir, but oftentimes when talking to healthcare professionals who don't work with immigrants, they often are surprised by the isolation, because their question is that, oh, well, they're all living in communities with other immigrants, so they must have social connections there. And that is not necessarily the case, especially if they are a more recent group of newcomers, that there isn't as much social connections in the areas that they are migrating to. And there's an assumption, just because everyone's from the same country, that they automatically, will create social connections. As many of you are aware, that isn't necessarily the case. I will say before I end this, though, and this is something when we train providers on the Forte program, I say repeatedly, is that while there is a high risk for all these things in our newcomers, we don't assume any of this. The only thing we assume that our newcomers will most definitely have is immigration-related stressors. The stressors of being an immigrant in a new land. We don't assume that there's trauma. We don't assume, that any of these things happen. We just really focus on the immigration-related stress, although some of these other areas will come out, throughout our program, in our discussions with them. And so, to make a very long story short, the program began about 7, maybe even more than that, actually began in 2013, where I am currently working, and being on a panel with Angie and Ryan is great, because both of them have been involved in this in very different ways throughout the process. Angie being our biggest champion at SFUSD, and Ryan helping co-author the initial version of our Forte program that then became the program that it is now. This took a lot of folks collaborating together. And back in 2018, it came to a head through leadership in the Department of Public Health here in San Francisco, myself, folks, leadership at different community-based organizations in San Francisco, Angie and San Francisco Unified. And we really realized that there was a strong need for a program like Fuerte, and a program that centered the voices of families and the youth. And through a number of community planning meetings, through a number of meetings with families, piloting of different versions of this program, we realized that San Francisco had a number of needs in terms of newcomer Latinx immigrant youth. There was no prevention program. There wasn't a program at the time that was school-based, that really was culturally responsive, informed by the voices of these newcomer youth and their families, that was trauma-informed, and that was community engaged. This was lacking in the district, and there was this Fuerte program that was being piloted at a time, but really had no funding and needed some sort of mechanism to be able to fund it so we could evaluate it and disseminate it out and scale it up throughout the district. And if you look closely, you will see some of us in these pictures here. And so what we ended up doing is we applied for an innovations grant through the Mental Health Services Act. For folks who are not familiar, or I'm sorry, for folks who are familiar with the Mental Health Services Act, then you are familiar with Proposition 1 that was passed last year, which has now rebranded this to the Behavioral Health Services Act. I'm going to stick to talking about this just for clarity. Things have changed, not significantly. So a lot of what I'm going to talk about in terms of innovation still applies, although the mechanisms and how it's framed is a little bit different. But because they haven't released official word of how innovation is kind of stands in relation to the Behavioral Health Services Act, I'm going to just stick to what we did back in 2018. But just putting that out there, if people are interested, the Behavioral Health Services Act is now where this sits, or or it's where it's always sat. It's just been rebranded, and some of these categories have been changed slightly, but most of this still applies. Happy to talk more in the questions too, if folks have questions. So what we ended up doing is we applied for what's called innovation funding. And this is for programs that have some promising evidence, but need funding to demonstrate that A, it works, and then B, to build out a way to scale the program up. It took a lot of work, and a lot of meetings that we put together. We put a report together. We sent the report to what was called the Mental Health Services Oversight and Accountability Commission, which is the state office that kind of oversees the innovation funding and makes decisions about funding it. They are now rebranded as well as the Behavioral Health Services Oversight and Accountability Commission. And we were accepted to present and went up to Sacramento, and as a group laid out our plans for what is now the Fuerte program, and were awarded this funding. And we were funded for 5 years to evaluate it. Our funding started in sometime in 2019, I believe it was March or April exactly. And it just ended earlier this year. Just as that we have now demonstrated enough outcomes to meet the San Francisco County's needs, the state needs for this, and now we've been officially funded under that prevention and early intervention category, so that Fuerte can continue and build out. And I'll talk a little bit about that, but just wanted to add there, this funding ended. So some of the information I'm going to present to you is all preliminary, kind of hot off the press. And we will have like more, detailed information as we're working through, since we just ended our last groups as part of this last school semester. And so what this funding allowed us to do is evaluate the program in 400 Latinx newcomer middle and high school youth in San Francisco Unified. Also, what the second goal of this was to start coming up with a plan to adapt the program to other groups of newcomers, and then also a plan for dissemination of Fuerte in other counties in California. And so what this allowed us to do, we went through various variations of the program, but the final model we basically came to, and the one we evaluated on, was this 7-session model. Everything is done in groups at the school. The groups are led by 2 facilitators. One represents the behavioral health system, so they're typically either a clinician in one of our specialty mental health clinics in the county, or a trainee that's supervised by someone trained in our program. And then the second co-facilitator is typically someone representing the school that the student is at. That is most often someone in the wellness centers at the schools, but sometimes it's been a school librarian, case managers, other folks who may be at the school who speak Spanish. We're willing to get trained in the program and co-facilitate these groups. We include up to 8 kids in each group. And again, it's very prevention based. There is no screening of kids to see if they're appropriate for the group. As long as they're considered newcomers, which at San Francisco Unified is 5 years or less in the United States, and they are here from a Spanish-speaking Latin American country, then they are eligible to participate in these groups and can participate. And the modules focus on identity development, particularly around immigration, acculturation, stress. We talk a lot about traditions and rituals and routines and the importance of keeping those and or starting those, as there's much that evidence to suggest that these things help with mental health and well-being. We learn about emotions and how to identify different types of emotions, especially complicated ones. We spend a good deal of that in one of our modules, and then how to manage stress through coping strategies. So things like relaxation skills, how to identify when you might need more help and reach out for mental health services. And then we talk about the immigration journeys and immigration stress in particular. And finally, work on communication skills. So how to better take the perspective of others and how they can better communicate their needs to other folks. And then finally, we also celebrate the accomplishments in the groups. And so some of our preliminary outcomes. So we served 351 youth. For those who have been paying attention, we didn't hit that 400 number, but if you recall, and if you think about the dates when we started 2019, we had a pandemic in the middle of that. So we had a lot of time, we were about a year and a half, where we either couldn't do groups or we were doing them over telehealth, and it was just a very different version than what we intended. But finally, we were able to serve over 350 youth in the time being and make up some of that time. The big number here is that we screen every single youth for behavioral health needs. For folks that are familiar with our mental health system, our public mental health system in California, you may be aware that every youth that enters our specialty mental health system has to complete the pediatric symptom checklist, basically a measure, a screener of mental health concerns. We use the same measure, same cutoff score that's used. And of our kids that we screen, 30% of them met criteria for specialty mental health services. That's fairly high for a population that wasn't screened prior for behavioral health concerns. So this was not unexpected, but it's also striking. We actually thought it'd be more like 20%. And 100% of these kids were linked to behavioral health services with one form or another. We are also seeing increases in mental health literacy and social connectedness, and hope to have more detailed data on that very soon. The other part of this is the adaptation process. I'll talk a bit at the end about some of the adaptations we've been doing, but I'll talk to you about how we've been designing this process. And we came up with this nice infographic that one of our team members put together, and that really lays out how we do this work. So we always start with initial community planning meetings. It helps us assess the specific needs of whatever population we are trying to adapt the programming for. Then we reflect and review this. We review our current materials. We try to assess whether it's fit for, fit for their culture, fit for the developmental relevance for whoever our target population is. And we may need to go back to these community planning meetings. So some of this isn't necessarily linear. We may need to go back and forth depending on different things that come out of each meetings and making sure that we're constantly getting feedback. I also should state that the community planning meetings, we include stakeholders that including the youth and families, but also folks who are serving these. These could be folks in community-based organizations and mental health, community-based organizations that serve the different housing or food insecurity needs of this population, and folks in the school district or legal services that have understand kind of the needs of this population to make sure that we're addressing everything that we need to. And then we look at the adaptation. We kind of take insights from the focus groups or community planning meetings that we led and really try to better understand these needs of the population. Then we collaborate. You've already said that word a few times. I'll say it again. This is key to this work for youth with high needs. You need a lot of collaboration among systems, and engagement with key stakeholders is important. And then thinking about how we're going to deliver things, how are we using the materials, how are we engaging kids in this? Different populations have different needs. Are we targeting social media? Are we doing this in person? Should this be in a school? Should this be at a community site, et cetera? And then once we have the materials, we gather feedback from our stakeholders just to make sure we're on the right page. If not, then back to the drawing board, make edits and go through the process again, and then implement, and keep running focus groups to really get a better understanding of what we're doing. So making sure this whole process is community engaged throughout. And so lessons learned, collaborative systems are incredibly important here. None of this work would be possible without all the relationships with both folks on here, as well as so many other people who've contributed to this work and continue to do so. We also learned during the pandemic that telehealth is a potentially viable option for this group. We actually have some good focus group data on this, that kids really found it feasible to do this over telehealth. They thought it would still help them connect socially over doing it, and it might be a potential option in areas where in-person services may be difficult, or there may not be enough providers who speak Spanish. There may be an ability to do this over telehealth. We are also exploring the role of paraprofessionals as co-facilitators. We've been tracking data on how people implement the program, and we really don't see a difference between a trained licensed clinician and like a wellness coordinator or a case manager. We do feel like they could actually be trained and be supervised then, and this will, of course, increase the pool, because that's been our biggest barrier to scaling this even further up, is having enough people to run these groups. And then we are exploring youth as peer support. So how can we more involve these youth in this work? Many of them are employed in jobs, many of them working 40 plus hours a week. Why not harness that energy, pay them a good salary, have them start to create pathways for them to enter, especially, my biased view, healthcare careers, because we need them. As we are really in need of making sure that we have the behavioral health workforce in the future to serve everyone. And so next up, as I mentioned, we have several adaptations. We're going to have a pilot of our adaptation to our younger kids in elementary schools. This will start in February or March of this year. We are in various phases of adapting this to Middle Eastern, North African youth, Chinese and Filipino youth, and then also looking at a version of the program that includes peer supports. And these are all in various stages of development, and hopefully by the end of this year, make more headway in each of these areas. I believe that should be it for me. Yeah.
Great.
Thank you. I'm happy to answer any. I haven't been monitoring the chat.
We've got a few for you. Thank you so much for sharing about Fuerte, Will. there were a couple questions coming in about the role of the family within this work. And so I'm curious both, to what extent you do engage with family or guardians, and if you need any sort of consent form.
Yeah, and this is Family Guard. So that's a good question. So we made actually the initial decision to we had their feedback in the groups, but because of the challenges with getting guardians with especially with our unaccompanied minors and because we were focusing on high school youth and middle schoolers, we decided that we would do what's called passive consent. We send letters home to the families telling them that, about the program. And if they have a concern, who to call if they don't want their youth to participate. But otherwise, the youth are self-consenting in the school. And
Yeah.
all of this is being ran through wellness centers or the equivalent. And so there's already that process going on at the school site. So and to my knowledge, yeah, to my knowledge, I did there. We've not never received anyone saying they didn't want their kids to participate.
Great to hear.
Yep.
And I'm wondering, in terms of the pacing of these sessions, 7 sessions, over what period of time does that happen? And is there some sort of like maximum space between sessions that you don't want to go past so you have momentum and cohesion?
Yep. Yeah. So each session is ideally an hour and a half. In the schools, that is difficult to have that much time. So we ask for at least an hour, and that is typically what we get. It's an hour a week. So we do, it usually takes about 7 to 8 weeks. Sometimes some of the sessions folks will do over two different sessions. So they'll split, like especially the one around coping strategies. They
Yeah.
may do half of it over 1 week and then another. So it could be an 8 week long program. But typically this is meant to be brief.
Yeah,
But yeah, I wouldn't space the sessions more than 2 weeks apart, just to
that's
keep the
useful to
momentum,
hear.
as you said.
Well, and I'm wondering, there are probably a lot of folks listening who might be interested in emulating something similar to your program. We'll send out the website afterwards, it's linked in the chat. If people are going through those resources and feel like they want to do something similar, and they don't have a partnership with UCSF, and maybe they don't have a grant, what can they take from the Fuerte program materials or from your experience back to their site in a potentially lower resource context?
Yeah, that's a great question. I would say a good place to start would be finding out what their county's Behavioral Health Services Act office is and understanding better there, who to speak to. Typically, there's a program officer or equivalent role at that office that you can talk to about what your programming is, what needs it fits, and see if there is potential for funding there. There's a lot of funding, particularly around prevention for children, that has come down through Proposition 1. Um, and there may be opportunities there at the county level. You can also reach, if folks are trying to navigate that, feel free to reach out to me. I can help you figure that out and who to talk to in your county.
That's awesome. I just heard Will volunteer to put his email in the chat
You can do
for
that.
for consultations, for grant writing support.
Yeah,
But
not for grant writing, but for consultation. So,
thank you so much, Will. The program sounds wonderful, and it's great to hear about it in terms of sparking our thinking for other local efforts. And now I'm so excited to turn it over to our colleagues at Stanford School of Medicine, starting with Ryan Matlow.
Yeah, thank you, Sam. Thanks everyone for being here. My name is Ryan Matlow. I'm a child clinical psychologist as well at Stanford. And yeah, I will just say I am grateful to be here in community with everyone. As Angie said, when we're facing tough times, the most difficult thing is to be doing that in isolation. And so I just really appreciate being in a community space. It's always galvanizing and energizing to be connecting with folks who are doing similar work and have a similar dedication and kind of shared value set around supporting the well-being of newcomers. So thanks to Sam and thanks to CalNEW for hosting this and bringing us all together. It's been energizing already to kind of be in the space with you all. So thank you. And okay, yeah. Yeah, so I'm going to be sharing a lens and an approach for understanding and addressing the impacts of immigration-related adversity and trauma. And I will be focusing a bit more on individual level considerations for trauma-focused and trauma-informed supports for newcomer students. Angie and Will have shared a bit around kind of the universal and group level supports. All these layers and levels are absolutely important. And just in the time that I have, I'll be focusing more on the individual approaches and considerations. And I will say that while the delivery of some of the kind of like interventions and supports that I'll be talking about is the realm or the kind of primary domain of mental health professionals, we believe that it's important for all folks in education to have an awareness of some of the promising practices and know a bit about kind of what we're doing in trauma therapy. And so I hope that this material is helpful for understanding and thinking about how best to support your newcomer students. And I will lastly apologize in advance that my slides are a little bit text heavy. I'll be covering the content at a high level, not going to go through everything that's in my slides, but wanted to include a lot of information just as a resource and reference for folks. Great. And so as has been stated, we know that newcomers experience high rates of trauma and adversity exposure both before, during, and after migration. And that these experiences are contextualized by histories of cultural and intergenerational trauma that exist within the communities and countries where many newcomer kids are coming from. And in particular, we know that many of the experiences that kids have upon arrival at the U.S. To the United States or at the U.S. border, experiences of detention, experiences of being expelled and forced to wait in Mexico, the various forms of family separation that have happened and continue to happen. These experiences often undermine the existing strengths and resources that many kids are coming with. And just as a little bit of a reference, just tagged and highlighted a kind of report or a guide that we collaborated with the National Center for Youth Law, just kind of detailing and discussing some of the implications of the experiences of kids who arrive in the United States, particularly unaccompanied children. And so we know in the field of trauma psychology or trauma mental health that the kind of accumulation of stressors and adversities faced over childhood, faced over the different stages of migration, in conjunction with the threats to resources and resilience and strengths, creates this heightened risk for a variety of traumatic stress reactions. Folks are likely familiar with a lot of these. They can include the kind of classic experiences of depression, anxiety, or PTSD. Also, some of the broader, more pervasive impacts of exposure to multiple complex or different types of trauma over the course of childhood development within the caregiving environment that we know impacts general behavioral and emotion regulation skills. It can impact cognitive and like attentional functioning, right? And it can impact how we just relate with ourselves and with others around us. And then folks that are familiar with the ACEs research also know that the impacts of traumatic stress or toxic stress have significant impacts on our health and biological outcomes. And so again, despite the newcomers' incredible strengths and resilience, these numerous stressors and impacts can erode a lot of the protective factors that they're coming with and create a psychological weight or a burden we kind of like represent with this backpack that many kids are carrying that just can become overwhelming. And so as educators, many of you know that the challenges stemming from the impacts of trauma often show up in the classroom setting, whether it's the distress or anxiety related to adjustment and acculturation, adjustment to the new school environment, some of the things that Angie spoke to, whether it's the presence of the kind of common fight, flight, or freeze reactions that we see in a trauma response when kids feel a sense of threat to their well-being or when there are reminders of kind of prior traumas that they've experienced or things that they've experienced in their lives. Or some of the kind of internalization of the messages that kids may have heard and experienced. Again, the messages that are out there in society that immigrants don't belong, or some of the things when kids are struggling academically, they may have doubts about their own kind of capacities and intelligence, when really that's related to other structural issues, right? Gaps in their learning, having to learn in a new language, right? And so when these things happen, when you see these impacts, it's important to think beyond the single events and incidents, to really consider the cumulative toll of the multiple stressors and adversities that newcomer kids have experienced. And the other important point that we want folks to kind of keep in mind when you see these things is that it's important to remember that a lot of these kind of reactions are normative and often protective or adaptive responses in the context of threat and adversity, the environments that kids may have experienced in their communities of origin or during the migration journey, right? But they often prove maladaptive or challenging in the context of what we hope is a safe classroom setting. It's like the thing that helped you survive in one context is getting you in trouble in the context you're in now, right? So it's there's a strength-based approach that we can hold even when we're challenged by what we're seeing, by what's kind of presenting in the classroom or in the school setting. And so, yeah, in spite of the challenges that teachers and educators are going to inherently face when these kind of reactions and manifestations show up, we encourage you to approach these challenges with curiosity, right, as like an opportunity to understand newcomer students' experiences and to build on their existing strengths and resources. And in the context of trauma, we know that there are precipitants or kind of precursors to these reactions, to like the behavioral manifestations of traumatic stress, right? The kind of cues and triggers that elicit those trauma responses, that elicit those fight, flight, or freeze reactions. For all of us, through history and learning, experiences, sensations, stimuli in our environments that may be neutral or may not be like dangerous or threatening in and of themselves become paired with like our trauma experiences, right? Or trauma responses, again, those fight, flight, or freeze reactions. So again, that reaction then shows up when that cue or reminder is present in like the current environment in the classroom setting, for example. And so it's helpful to be thinking about what these cues are, what these triggers are for your students and for their community, so you can understand what is happening for them and be prepared to support them. Some of the common cues and experiences, kind of reminders or triggers that we see is, not knowing what's happening in your environment, right? This is a common characteristics or a common experience through the migration journey, right? Being overwhelmed by unfamiliar circumstances, environments, of course, feeling threatened or feeling that there are threats or risks to your safety or well-being, feeling undervalued or discriminated against. Again, this is the kind of the history and the context that so many newcomer kids or immigrant kids are coming from, and then feeling a lack of control or agency over one's own experience, right? These are all kind of like common cues or common experiences that can be triggering for all of us, but particularly for newcomer kids, given their prior experiences and histories. And I understand, recognize I'm talking in generalities here. This doesn't apply to everyone, and we don't want to make assumptions about what's true, but this is some of the common things that we see. And so I am just I'm drawing here a little bit from cue-centered therapy, some principles and concepts that are emphasized in CCT, which is a psychotherapy, a treatment approach that considers this cumulative impact of complex or chronic trauma, and then focuses on the cues and triggers that evolve over time to elicit those trauma reactions, right? And so this is an intervention approach for trauma that can be readily applied to address migration-related trauma and adversity for newcomers. Cue-centered therapy, or CCT, aims to build skills in cognitive, emotional, bodily or physiological, and behavioral regulation, these kind of 4 domains that we kind of depict in this square here. And then we help kids apply these skills in the face of their trauma cues or trauma reminders to give some kind of flexibility in their responses. And so there's a little bit of a call here, just as I kind of introduce and talk about CCT, just a call for like general school staff, knowing that there are many opportunities to collaborate with mental health professionals who are doing trauma therapy, such as CCT. There's so much coordination and kind of sharing that can happen around building a shared understanding for what's happening for our newcomer kids, for identifying some of the unique cues that are relevant to their experience, developing some of the coping safety plans and kind of bringing those into the classroom, right? Applying the learnings from therapy in the classroom setting. And so just to take a little bit of a deeper dive into some of the elements of CCT and some of the things that we do, part of one of the components is to build a life timeline that really maps kids' life experiences and really helps both the provider and the student themselves, or the young person themselves, understand their context and help gain an understanding of the impacts of their history. There's a kind of normalization and validation for some of the things that they're struggling with in looking at this whole full life context. And so in this life timeline activity, we're identifying both experiences of threat and trauma, as well as moments of strength and recovery. So this is essentially an activity, a process in therapy that is offers a visualization of that cumulative burden, that load that kids are carrying. But also importantly, we work to identify a lot of their positive life experiences that can oftentimes be a source of resilience and hope as kids, continue in the adjustment process, right, and kind of establish their lives or kind of the next steps in their journeys. Another kind of main element or activity in Q-centered therapy is an exposure, a process of gradual exposure. So we're helping kids confront and face some of those cues and reminders, things that are not necessarily inherently dangerous in and of themselves, or kind of formally neutral experiences, sensations, stimuli in the environment, kind of types of interactions with people, but have evolved to elicit some of those trauma responses and fight, flight, freeze reactions. And so in this exposure process, kids, we support youth in practicing using these new responses so that they don't always get stuck in these fight, flight, freeze reaction patterns. And it helps to build a sense of empowerment and agency through experience, again, countering some of the things that can be cues or can be stressful for youth. In the last couple moments that I have here, I just want to plug, well, I want to say that again, like CCT fits into the RTII MTSS model, again, is like a tier 3 intervention for newcomer youth. But we are also thinking about broader interdisciplinary collaborations and systems of care that comprehensively address newcomer student needs. So this is another activity that we're working on in our program, in our kind of local context. For me, I'm thinking about, as a psychologist, I'm thinking about how trauma therapy work is conducive to supporting students' educational, health, and legal needs amongst others, right? And vice versa. How can understanding of kind of legal processes inform like my work as a psychologist, right? And so what we're trying to do is think about how we can improve coordination across our typically siloed systems and disciplines. And so over the last couple of years, we've been convening and organizing a group of providers, service providers from the local context and community here in the Bay Area, using a kind of collective action co-creation approach to work towards this kind of like model program or model system of care. Systems change is hard, and so we're kind of building from the ground up, right? But we've been organizing a convening space that, again, is a resource for service providers, where as a community, we've been coming together to collectively identify some of the challenges and best practices that we experience in supporting newcomers, where we've built connections to support multidisciplinary cross-system collaborations. Our colleague, Dr. Suleiman, will share a specific example of one of those collaborations in just a moment here. And we've been working to collaboratively design initiatives that help us build towards this model system. So I'd be happy to connect and talk more with folks who are interested or interested in learning about this kind of convening process and some of the initiatives. It's been a really kind of valuable experience, again, of just kind of being in community and, again, working across, in particular, there's emphasis on working across sectors and disciplines and, again, breaking down some of the barriers across our silos. And yeah, just a couple of examples of initiatives. One of the things that is taking off that has been kind of co-designed in this space is a multidisciplinary case conference space where we're kind of, again, coming together across systems to think about how do we coordinate care and services for youth that are entering for newcomer youth that are entering our community and our systems of care. And then another one that is focused on delivering immigration law trainings for educators, kind of upskilling educational and school staff to help them support and address some of the legal concerns and issues that they're seeing for their newcomer communities and newcomer students. And so, yeah, I mean, just this effort in general has helped us all be a little bit more effective in navigating our local systems to support newcomer students and families. Of course, we're all unnerved and impacted by what's happening with the new administration. And at the same time, we're affirmed that now, perhaps more than ever, is a time to be coming together as a community. And so we are both very anxious, but also very kind of excited for what's going to come, in the years ahead as we continue to work together and collaborate and be in community with one another. And so let me just some additional resources here. There are links for ways to learn more about Q-centered therapy and some training opportunities and things like that, and links to that resource guide that I mentioned earlier. But I will stop there and pass things along to Shazeen.
Thanks, Ryan, and thank you, everyone. I'm really excited to be here. I'm a pediatrician. I am also an associate professor at Stanford, and this work is really meaningful for me personally. I'm the child of refugees, so a lot of the work that I do is informed by my own family experiences and my community experiences. And also hearing about the news now is very relevant to some of the feelings that I have and see in my own family. I guide my work a lot by thinking and reminding myself that no child has ever chosen to be a migrant. Often these decisions are made for them because of political factors, because of economic factors, but really because of some other adults making decisions in their life that are choosing this path for them. And this is what I hold in my heart and in my mind when I have conversations to advocate for children. I also wanted to hold in our minds that recognizing that we use the word newcomer, but newcomer isn't the same for everybody. Not every newcomer has the same journey, and not every newcomer has the same health status. A lot of it depends on their health status pre-migration and what their migration journey was like. Some folks might have heard about something called the healthy immigrant effect, which is often cited in the literature, that immigrants have better health care than some of their native-born counterparts, but that might not be true for individuals who are coming as refugees or asylum seekers. We also know that the migration journey itself is not the same for every newcomer. And post-migration, when they come to their host country, your immigration status determines your access to services and care. And so as a determinant of health, your immigration status will change what the healthcare status is for newcomers. So it's just important that we hold this in our mind, because often we might have a construct in our head of who is a newcomer, but I'd like to challenge that and realize that that could look so many different ways. So as we think about the migration journey, pre-migration, it really depends on the healthcare infrastructure that children have access to before they come. Many children now, sadly, increasingly around the world, are also coming from conflict zones where healthcare infrastructure has been destabilized with environmental exposures to infections, and reduced access to preventative care globally. The concept of preventative care is not a thing that we see across the world uniformly. And of course, as we've heard, even pre-migration, there's exposure to trauma, to poverty, to food insecurity, to housing insecurity, to family separation. We now know that in the transit journey, we don't know what that's like for every child, but that can also be accompanied by difficulties like overcrowding and poor sanitation, particularly for refugee families who may have had to go through multiple countries of origin, or asylum seekers. Adding to these environmental exposures, I have seen families who have come through many countries, more than 10 or 11 countries, on foot. And that has to shift then the kind of exposures that I'm thinking about, because it's no longer just their country of origin. And of course, we know that once you arrive at your host country, what happens on arrival is very different. You may experience detention, you may experience family separation, you may experience expulsion, you may also be coming alone. And when you arrive here, there's all these other healthcare considerations that as educators, I know you think about often, beginning with how to enroll in school and getting the vaccinations that you need that's required in the state of California. All of these other social determinants of health, like food, income, and housing insecurity, also affect the physical health of the children that we see. And trying to get access to these services and navigating these services, including Medicaid, can be so difficult. In addition to some of the mental health traumatic effects, we often will see that manifest physically. You might see children present with chronic conditions like pain, stomach aches, headaches, difficulty concentrating. We know that telehealth can be such a wonderful tool, but it may also be difficult for families to access with the digital divide. These are just some considerations along the healthcare journey for us to think about. So as I was preparing this talk, I was thinking, and I work very closely with a number of school districts in the Bay Area. And I was reflecting with them. I said, what would be some things that it would be helpful for me as a pediatrician to have in partnership with educators? And so you spend so much time with students and families and have so much brokered trust that I think of you as a really critical partner in healthcare navigation. Many students who we see who've newly arrived in the US healthcare system have interacted with healthcare systems that operate very differently. For example, I'm Canadian, and when I came here, I still found the system really hard to navigate, despite being a professional in the system. It's quite different from what I'm used to. And when you look at the global South or people coming from different countries, the words that we use may not actually mean the same thing to every provider. Preventative care is not routine. Primary care provider doesn't mean anything. Insurance, prescriptions, referrals, these are all new concepts that are so normalized for us who have been in the system, but in many parts of the world, this doesn't exist. And educators can play such a huge role by just explaining in the US, all children have a doctor or a nurse practitioner who can be who they see to keep them well and to keep them sick. If you need a medication, what you can do is you'll go to the pharmacy and give your card and your name, and that's when the pharmacist will give you a prescription or give you a medication. Just explaining all of these little steps that seem very normal to us that have been in this system. Another thing that can be so helpful is helping get vaccination records together and helping families understand why they're required. Again, as Dr. Matlow explained, and so did many of the others, when you are in a new place, it is hard to know what your information is going to be used for. And that can elicit feelings of mistrust and weariness with families who are newly interacting with you. And so having someone trusted like yourselves as educators help explain that all this is doing is making sure that your children are protected from infections so that they are safe and students are safe. And the way we do that is through making sure we know that your children are up to date with all of the vaccines that they need to be healthy at this time. These vaccination records can be from their country of origin, or often if they come and are placed into ORR custody, ORR will initiate some of those vaccines, but they are not uniformly kept, particularly if they didn't come through the state of California. So anything you can do to help those families collate them, keep them on their phone is helpful. For your information is that if there are no records available, we do a full immunization. Many parts of the world use an oral polio vaccine because it is shelf stable and doesn't have to be refrigerated, but that is not the same polio vaccine that we use in North America. So they will need that to be re-immunized. And most kids around the world do not get a varicella vaccine. It's not uniformly given, but many might have had chickenpox in the past and so don't understand why they have to get another vaccine. They often need multiple doses. And I've heard from so many youth, why do doctors just keep giving me 5 or 6 vaccines every time I go? And helping families understand that multiple doses are needed at intervals, again, coming from trusted folks like yourself, will just ease them on their journey. Additionally, helping them understand that we may need to do blood work, and what we're screening for typically is tuberculosis. We also screen for STIs in all children, and the reason is not because we are suspicious, but because prenatal screening for these diseases is not done uniformly around the world. And you would be shocked at how many times we pick up chronic infections for the first time in a 7, 8, 10-year-old because their parent had never been screened for hepatitis C. That's why we do this screening work. We also look for other vector-borne diseases. So these would be parasites. These would be things like strongyloides that they might be totally asymptomatic for. We look for nutrition levels. We look for exposures like lead. And we might look for other conditions based on their own ancestry and the countries that they've transited through, thinking about their exposures. I have picked up a number of chronic diseases this way in doing their blood work, again, because not all children have the same access to care. Additionally, we do a lot of universal screening programs like infant hearing. When a baby is born, their ears are checked. We do vision screening on preventative at every well child visit. Kids can have access to dental care. These are, again, not uniform around the world. And I have seen many children. I can think of one case that I saw most recently, who was a 15-year-old boy who was treated as if they had an intellectual disability, but it was because they had hearing loss and had never been tested. And so students might be only identified through school-based screening programs and for the first time when they're coming into our system. And so thinking about this for every child that you see, making sure that they're able to get a vision, a dental, and a hearing test if needed. I also recognize that it may take multiple visits, multiple times for a child or youth to go to their pediatrician to complete what we would normally do in one visit. And this is because we're trying to establish trust ourselves as a healthcare providers. We often work with interpreters because recognizing that newcomer families come from a variety of backgrounds. And while we try to have bicultural and bilingual speakers, it's hard to do for every language and every culture. And so when you're working with an interpreter, it often will take more time. And we know that families may not want to share right away with us, which is why it takes time. But as, again, seeing you as a trusted provider and a collaborator in this journey, helping families and youth know what will happen can be so helpful in keeping them healthy. So other things you can do, if you can help explain how insurance works, set them up for Medicaid. As you know, right now, as of today, still every child and actually every person who qualifies for income eligibility is eligible for Medicaid in the state of California, independent of their immigration status. I would encourage us to make sure everyone is registered as soon as possible, help set up their appointments, and help anticipate next steps. And one thing you can do is something that we, Dr. Matlow kind of alluded to this, is we heard that in our county that there were a lot of youth coming to a newcomer welcome center who were having delays in enrolling in school because they couldn't get an appointment. So all I did was create a smart sheet that the newcomer welcome center could just put the information in for the parent, and we would call the parent with the appointment. And once they come for their appointment, we have this multiple step process where they might come for vaccines, and then a couple weeks later have the first part of their physical, and a couple weeks later have another part. And in every step, we connect them to a little bit more. But just recently, we started with one school district. It then expanded to the elementary school district, and now it's with the third school district because everyone's really excited about this. And since we started this process in September of last year, we've had 450 students come through that are now enrolled in school. We've picked up so many different conditions. Many of these children have special education requirements. And we've been able to, one case I can think of is a child who's never been to school, who was 18, who has cerebral palsy, that we were able to identify and now is in an extended adult program. And she sent us pictures of her graduation because she was so excited. And out of this, we've also been working with youth directly. One of the areas that I have some expertise in, and I'd love to share with anyone, is co-designing with community and co-designing with young people. So with a team of 9 youth themselves, many who have come unaccompanied, many who didn't have status when they arrived, we asked, well, what could make it better for you to navigate the healthcare system? And what's come out of it is that they said, we want to learn ourselves because our parents come to us and our peers come to us. So we're now developing a healthcare navigator program. And this is actually a picture from our most recent session where we were doing training on healthcare and legal support navigation. And we're building little toolkits. They're going to be ambassadors. We got funding for them to be paid. And I'm hoping that we might be able to roll this out once we pilot it in other CalNEW districts if you're interested. So stay tuned. Tried to go as fast as I could, but hopefully that was informative and interesting to folks. And I'll turn my mic off.
That was wonderful. Thank you for turning your mic on, Shazeen and Ryan. I think we'll skip the panel discussion today because we just have a little bit of time left. But I'm wondering if anyone would like to ask any questions of Ryan and Shazine, as we just had that great overview of both physical and mental health. And maybe I'll just kick it off, Shazine, as we wait or see if anyone else comes with a question. I'm curious, there's such promise in that sort of youth navigator approach. You were just saying how hard it was for you, even as an advanced professional in the field speaking English. I'm curious how you see that sort of model potentially scaling or spreading in different places.
I think what is almost what the problem is, it's not that there's no information, it's there's too much information and you don't know where to look. And so what I see happening is that if we can condense this into a youth-friendly oh wow, my face just turned huge on the screen. But if you can make a package that, again, the youth are telling us what this needs to look like, how they want the information to be relayed, right? I'm hoping that this can be a toolkit that can be disseminated with training materials that anyone in the state of California, any educator who has a team of youth wants to do. And kids learn best from other kids, right? We know that. They're not going to listen to the old adults like me. But I think if we can make it something that's openly accessible, the one part that I wonder about for sustainability that we are doing in Sequoia is I did get funding so that the youth could be paid to be the ambassadors. And I love that because I really believe in youth being compensated for their work. But that might be something that we have to think about in terms of our budgets and where that can grow. I don't know if I answered your question at all.
It's good enough. I'm just hearing that you're gonna make resources accessible to everyone, and then we're going to pay kids to use those resources and do good work. And I think that does raise up a best practice that we've seen in a lot of places, that often kids need the money to stay in school. And they're often the best at doing the work that needs to be done too. So anytime that you can repurpose funds for students to do work that they want to be doing and can do more effectively than people, you're also going to get a better bang for your buck than working with another agency potentially. So it's good in all ways. Thank you so much to all of our presenters for sharing your knowledge. The fact that there's still, 100 people here at 5 p.m. on a Thursday of a long week is, a testament to how much our community cares. So be well, everybody. Take care of yourself and others, and look forward to seeing you again.